Hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Dalcina Bean Burrows, and this is lecture number 12. And in today's lecture, we will be discussing immunity and healing. So in today's lecture, we will be first looking at the learning objectives, the key terms, the organs and tissues of the immune system, the nonspecific immune defenses, specific immune responses, acquisition of immunity, aging and the immune system, psychoneuro-immunology, and thoughts on holistic healing. Now, before we get started, when you have a flu, your whole body can ache. Can you speculate as to why? And also, flu and other vaccinations are often promoted as safe and effective for preventing or lessening the impact of certain illnesses. What are your personal beliefs regarding vaccines? Now, in terms of today's learning objectives, upon completion of this chapter, you will be able to explain the function of the immune system and discuss its relationship and importance to manual therapy practices, explain the difference between primary and secondary lymphoid tissues, name, locate, and describe the general functions of primary and secondary lymphoid tissues, and explain the difference between nonspecific defenses and specific immune responses. List the nonspecific immune defenses of the body and explain how each mechanism works. Name and describe the roles of the primary lymphocytes involved in antibody and cell-mediated immune responses. Discuss the difference between naturally and artificially acquired immunity and give examples of active and passive forms of each. Discuss the immune system changes that commonly occur with aging, and define the field of study known as Psychoneuro-immunology and explain the implications of this discipline for the practice of manual therapy. Now, in terms of the key terms that we will discuss today, they are antibody, antibody-mediated immunity, antigen, antimicrobial, cell-mediated immunity, immunity, memory cell, microbe, natural killer cell, nonspecific immune defense, pathogen, psychoneuro-immunology or PNI, and specific immune response. Let's begin today's lecture by considering the body cells, the tissues, and the organs that work together to protect and defend us from a continuous stream of disease-causing agents, known as pathogens, that challenge our health and well-being. Like a standing army on alert, the body has a multifaceted defense system to provide what is referred to as immunity or protection from or resistance to infection and disease. In today's lecture, we will provide an overview of the organs and tissues of the immune system and describe their specific functions and the protective mechanisms the body employs to fight immune challenges. Once an immune challenge is passed and its physical symptoms have subsided, the body goes through a recovery phase that returns cells and systems to their normal metabolic status. This recovery phase, like the duration of the immune challenge itself, may be short or long. While for centuries, Western medical science approached immunity and healing as purely physical processes, it is now generally recognized that physical healing is profoundly affected by stress, emotions, beliefs, and attitudes. Manual therapists and other holistic practitioners will appreciate psychoneuro-immunology, a science that studies the connections between psychological processes and the immune and nervous systems. The science of P&I, which is how it is referred to, challenges all healthcare professionals to think about healing in a more holistic way and provide insights into touch, love, and laughter and how they are simply good medicine. Let's take a look at the organs and tissues of the immune system. Organs and tissues of the immune system are not all physically connected. Instead, they are scattered throughout the body. Some are structural components of the cardiovascular, lymphatic, or endocrine system. These structures of the immune system are primarily divided into two broad groups: primary and secondary lymphoid organs and tissues. The primary lymphoid organs and tissues that produce lymphocytes include the red bone marrow and the thymus. The secondary lymphoid organs and tissues are the sites where the majority of specific immune responses occur. These organs include the lymph nodes, the spleen, and the unencapsulated masses of lymphoid tissue, such as the tonsils and Peyer's patches. And here we see illustrated the development of lymphocytes. Lymphocytes originate in red bone marrow as lymphoid stem cells. Some remain and mature into B lymphocytes, while others migrate to the thymus to become T lymphocytes. B and T cells are then stored in secondary lymphoid tissues, such as the lymph nodes, spleen, and moats. Now let's discuss the secondary lymphoid organs and tissues. Secondary lymphoid organs and tissues are where specific immune responses occurs. Lymph nodes trap foreign particles for destruction, while the spleen stores lymphocytes, filters foreign particles and blood, and stores blood for emergency use. Mucosa-associated lymphoid tissue, or moat, are strategically located in the connective tissues of mucous membranes that line the respiratory, digestive, and reproductive tracts. Let's now consider the manual therapy applications with respect to secondary lymphoid organs and tissues. It is not unusual for manual therapists to be asked, "Do my lymph nodes feel swollen?" or "What do you think this lump is?" For this reason, it is important for therapists to know how to palpate the major lymph node beds and identify a single swollen node that might occur along a lymph vessel. Although idiopathic enlargement of a single lymph node can occur, generally, lymph nodes are not palpable unless there is an active infection. Swollen lymph nodes are about the size of a small grape or kidney bean and feel firm but not hard. Similar to lymph nodes, the spleen should not be palpable when healthy. If so, a client reports a tenderness along the left costal border and the therapist can palpate a firm spongy mass in that region, it can indicate an enlarged spleen and/or a severe infection. In both cases, massage is contraindicated and clients should be advised to seek immediate medical attention. Let's now discuss the secondary lymphoid organs and tissues, beginning with the mucosa-associated lymphoid tissue, also referred to as moat. The secondary lymphoid organs and tissues are the sites where the majority of specific immune responses occur. These organs include the lymph nodes, spleen, and unencapsulated masses of lymphoid tissue, such as the tonsils and Peyer's patches. These masses, known as mucosa-associated lymphoid tissue or MALT, are strategically located in the connective tissues of the mucous membranes that line the respiratory, digestive, and reproductive tracts. MALT has a high concentration of lymphocytes, giving these tissues the ability to quickly respond to foreign substances trapped within the mucus. The tonsils are small masses of lymphoid tissue located in the mucous membranes of the mouth and throat. They trap bacteria and other pathogens that enter through the nose and mouth. Like lymphoid lymph nodes, the tonsils swell and become inflamed when the immune response is active. There are three groups: lingual tonsils, pharyngeal tonsils, and palatine tonsils. Lingual tonsils, which are at the base of the tongue, also the pharyngeal tonsils, which are posterior to the nasal cavity at the back of the throat, and palatine tonsils, which are at the back of the mouth on either side of the opening of the throat. Peyer's patches are molds located in the lower portion of the small intestine. They trap and attack pathogens that have entered the body via the digestive tract. The appendix is a small twisted tube at the junction between the small and large intestines, also containing MALT nodules. This lymphoid tissue assists the Peyer's patches in filtering and trapping pathogens. Like the tonsils, the appendix can become infected and may require surgical removal. Time now for our What Do You Think segment. And remember, the What Do You Think segments are designed to help you to develop your clinical reasoning skills as you train and learn to become a clinician. The first question is, what are key distinctions between the lymphatic network and the lymphoid organs and tissues in this chapter? Why is it helpful to manual therapists to make these distinctions? The second question is, which specialized lymphoid tissue is structurally connected to the lymphatic vessel network? And the third question, what important similarities do you recognize among the secondary lymphoid organs and tissues? What are the important differences? Now let's discuss nonspecific immune defenses. The areas that we will look specifically at are innate immune defenses, physical barriers, chemical barriers, internal antimicrobial proteins, phagocytes and natural killer cells, and inflammation and fever. So now let's discuss the physical barriers, which are a part of the nonspecific immune defenses. Perhaps the most obvious example of nonspecific immune defense is the skin. Along with mucous membranes that line the respiratory, digestive, and reproductive tracts, the skin creates external and internal physical barriers, which are referred to as mechanical obstacles that block foreign particles. The tough, tightly packed keratinized cells of the epidermal layer make it difficult for tiny organisms or microbes to pass through and enter the body's internal environment. If this physical barrier is broken by a cut or scrape, pathogens can enter and the risk of infection increases. Besides serving a simple barrier, the epidermal layer continuously sheds to remove foreign particles from the skin surface on a regular basis. In a similar fashion, the mucous membranes provide an additional physical barrier to microbes. Sticky mucus secreted by the membranes traps foreign particles. In the case of membranes in the respiratory tract, coughing, sneezing, or movement of cilia propels the trapped microbes outside of the body. Now let's look at chemical barriers with respect to the nonspecific immune defenses. The chemical secretions and excretions of the skin and mucous membranes support the mechanical resistance of the physical barriers. Besides keeping the skin pliable and resilient, sebum secreted by the sebaceous glands creates a slightly acidic layer of protection that inhibits the growth of microbes. The pH of sweat, in combination with some of the enzymes it contains, creates an additional chemical barrier that destroys certain types of bacteria. Tears produced by the lacrimal glands wash the surface of the eyes, and saliva cleans microbes from the teeth, gums, and mucous membranes in the mouth. Any ingested bacteria are subjected to a chemical bath in the mouth and then assaulted by gastric juices in the stomach. Gastric juice, a potent mixture of mucus, hydrochloric acid, and enzymes, has a chemical composition that kills several types of microbes during normal digestive processes. The flow of urine and its slightly acidic pH cleanse the urethra and discourage bacterial growth in the urinary system. Similarly, vaginal secretions have an acidic pH that discourage bacterial growth as they help flush microbes out of the female reproductive tract. Now let's discuss the internal antimicrobial proteins as a part of the nonspecific immune defenses. If a pathogen gets past the body's physical and chemical barriers, it meets with a number of internal general defense mechanisms. 4 types of antimicrobial proteins found within various body fluids provide the first line of nonspecific internal resistance. Viruses cause disease by first invading the cells of the body and then replicating within these cells. Viral-infected fibroblasts, macrophages, and lymphocytes produce chemicals called interferons, which diffuse out of infected cells into nearby cells. Interferons induce the production of specific proteins that shut down the ability of a virus to replicate. In this fashion, interferon production limits the spread of a viral infection once it has occurred. Complement proteins. This particular group of proteins include about 30 normally inactive proteins found in blood plasma and body tissues. When activated by a pathogen, they initiate a cascade of reactions called the complement system, which enhances the immune response by supporting several other nonspecific immune processes such as phagocytosis, direct microbe destruction, and inflammation. Transference. Most bacterial pathogens require iron to support their metabolism. Transferons are proteins normally present in blood and other body fluids. When activated by pathogens, they bind to iron so it is not available to bacteria. And antimicrobial peptides. These short-chain amino acids are produced by macrophages and mucus-producing epithelial cells. When they come in contact with a pathogen, they destroy it by disrupting its plasma membrane. Now let's discuss phagocytes and natural killer cells. If a microbe survives its journey past the physical and chemical barriers and the body's antimicrobial proteins have not destroyed it, the next line of internal defense is provided by phagocytes and natural killer cells. You may recall that phagocytes are a group of cells that destroy microbes and other cellular debris by ingesting them, a process called phagocytosis. White blood cells, specifically the neutrophils and monocytes, are the primary phagocytes in the body. In response to chemicals released by cells at the site of infection, both types of phagocytes quickly migrate to the site, a process known as chemotaxis. During their migration through the bloodstream, monocytes transform into macrophages or big eaters. Macrophages have been previously discussed as primary cellular components of connective tissues. The stationary macrophages found in the skin, superficial fascia, liver and spleen, lymph nodes, and red blood bone marrow are called fixed macrophages. In contrast, macrophages that travel through the bloodstream and migrate into infected tissues are called wandering macrophages. Neutrophils and both types of macrophages play key roles in general immune defenses. Another key player in nonspecific immune defenses are the NK cells, or the natural killer cells. They are a type of lymphocyte found in the blood. While phagocytes ingest pathogens, they encounter NK cells and attach to the surface of infected cells and secrete a toxic substance that destroys its plasma membrane. This direct method of destroying infected cells is called cytolysis. In some cases, the cell is destroyed and the microbe or microbe of the particle are released into the bloodstream. If this occurs, the free-floating microbes are then destroyed through phagocytosis. NK cells make up 5 to 10% of all lymphocytes in the blood and are also present in the red bone marrow, spleen, lymph nodes as well. While NK cells have the ability to destroy a wide variety of microbes, they are particularly sensitized to tumor cells. Now let's consider inflammation and fever. Whether a tissue is infected or damaged through traumatic injury, the body defends itself through the process of inflammation. Inflammation involves the activation of chemical and cellular processes that enhance vasodilation, capillary permeability, clot formation, and phagocytosis to stabilize the damaged tissue and prepare the body for repair. When this process is initiated by pathogens rather than tissue trauma, the primary goal is to fight and contain the infection rather than to stabilize tissue for repair. In cases of infection, the classic symptoms of inflammation may shift slightly. There may be less localized swelling and pain, but an increase in heat and redness. In addition, a local infection may be accompanied by a thick whitish fluid called pus, which is a mixture of interstitial fluid, destroyed pathogens, phagocytes, and living or dead white blood cells. In cases of systemic infection or when a local infection spreads, lymph nodes may become enlarged and the core body temperature may rise, resulting in a fever. Elevated body temperature speeds up actions involved in enhancing tissue repair, killing or inhibiting the growth of bacteria, and increasing the effect of interferons. While it is important to control fevers of 104 degrees Fahrenheit or more, it is not always helpful to decrease a low-grade or moderate fever because it simply indicates an active immune response. In some cases, inflammation can continue for months or years rather than as a short-term response to injury or infection. There are many possible causes for this prolonged or chronic inflammation, including failure to eliminate the pathogen responsible for acute inflammation, recurrent instances of acute trauma, autoimmune disorders, or long-term exposure to low-level irritants or biotoxins. general body aches, depression, anxiety, or mood disorders, weight gain, fatigue or insomnia, and gastrointestinal issues can all be possible signs linked to chronic inflammation. Additionally, frequent infections are not unusual since the immune system resources for acute inflammation have been depleted. Risk factors for chronic inflammation include obesity, smoking, a diet rich in saturated fats and refined sugars, stress, and sleep disorders. Table 12.1 illustrates the nonspecific immune defenses. The first defense is the physical barriers, the components of which are the epidermis of the skin and mucous membranes. It functions to form barriers that physically block microbes from entering the body. The next physical barrier is chemical barriers, and these components consist of sebum, which form a protective acidic barrier on the surface of the skin, sweat, which discourage microbial growth and enzymes and pH, tears and saliva, which bathe and wash away microbes and kill them with the antimicrobial protein lysosome, gastric juice, which destroy bacteria and other pathogens that reach the stomach with a mix of hydrochloric acid and enzymes, urine, that flush the urethra and inhibit microbial growth with pH, and vaginal secretions. They flush the vagina and inhibit bacterial growth with acidic pH. The next barrier is internal antimicrobial proteins. This consists of interferons, which protect surrounding unaffected cells from viral infection, complements, which support phagocytosis, microbe destruction, and inflammation, transferins, which bind with iron to inhibit bacterial growth, and antimicrobial peptides, which cause cytolysis of microbes. The next defense is phagocytes. These consist of neutrophils and macrophages, and they eat microbes and cellular debris, which is referred to as phagocytosis. The next defense is NK cells. These kill infected cells through cytolysis. Inflammation is the next defense. Inflammation fights and contains infectious agents by increasing vasodilation, capillary permeability, and phagocytosis. It also prepares the tissue for repair. And fever. Fever speeds up metabolism to facilitate tissue repair, to kill or inhibit the growth of certain bacteria, and to increase the effect of interferons. Time now for our second What Do You Think segment. What analogy from your everyday life could you make to describe nonspecific immune defenses and responses? Have you heard the term antimicrobial before? In what context? What kinds of antimicrobials do we use in our everyday lives? What is the difference between how phagocytes and how NK cells protect us? Now let's discuss specific immune responses. In contrast to nonspecific or innate immune defenses, specific immune responses, also known as adaptive immune responses, are acquired over time through exposure to specific pathogens. These immune defenses involve the B and T lymphocyte responses to specific pathogenic agents. These pathogens may be bacteria, pollen, viruses, parasites, or toxins, but each has a specific chemical marker called an antigen. You may recall that an antigen generally is a protein on the cell membrane, and it identifies a cell as a foreign particle and stimulates an immune response. Since B cells and T cells have distinct antigen receptors on their surfaces, they can recognize and react to antigens. For each unique antigen, there is a lymphocyte with a corresponding antigen receptor. There are millions of B cells and T cells in the body, each ready to do battle with a particular pathogen. B cells and T cells produce different types of immune responses. The response initiated by B cells is an antibody-mediated response, while that initiated by T cells is a cell-mediated response. In most cases, both specific immune responses are stimulated by any particular pathogen. So, as we mentioned, B and T lymphocytes respond to specific pathogenic agents, while B and T cells recognize and respond to particular pathogens. Antibody-mediated immune response, or AMI, is illustrated here. With antibody-mediated immunity, activated B cells divide and multiply to create antibody-producing plasma cells and memory B cells that are stored for future immune challenges. This illustration shows cell-mediated immune response, or CMI. With cell-mediated immunity, the phagocytes engulf, process, and present antigens to inactive T cells. Activated T cells divide and multiply to create cytotoxic T cells, which directly battle the antigen, and memory T cells, which are stored for future immune challenges. Let's now consider the manual therapy applications for specific immune responses. Manual therapists must consider extra precautions when working with immune-compromised clients, such as elderly people, people with HIV and AIDS, those undergoing dialysis, chemotherapy, or radiation, or anyone taking medications that weaken their immune system. For immune-compromised clients, exposure to infection or illness can be dangerous. It is advisable for therapists to reschedule appointments if they are suffering from a cold, flu, or infection. Maintaining standard hygiene precautions, including frequent hand washing and proper cleaning and sanitizing of linens and equipment, is essential. It is also recommended that manual therapists consider vaccinations for hepatitis, measles, mumps, diphtheria, and whooping cough, especially if they are working in hospitals or other healthcare settings where there is a high risk for exposure to these highly contagious conditions. Now let's consider acquisition of immunity. There are two key characteristics that set specific immune responses apart from nonspecific defenses. A specific immune response occurs only in reaction to a particular antigen. Lymphocytes have the ability to remember exposure to a particular antigen. Our bodies maintain an immunological memory because of the memory cells produced with each episode of a specific immune response. These memory cells have the same antigen receptors as the original B or T cell that produced them and can live for decades. Upon subsequent exposure to a particular antigen, the memory cells quickly divide and multiply just like activated B or T cells. While memory B cells produce plasma cells and more memory B cells, Memory T cells produce cytotoxic and memory T cells. Considering the number of memory cells produced during initial exposure, it is not surprising that subsequent responses to a particular antigen are quicker. During initial exposure, there are only a few lymphocytes with the correct antigen receptors to initiate a response. During a second or subsequent exposure, there are thousands of memory cells available, which increases the possibility of the antigen activating one of these specific lymphocytes. The second response is also more intense. The large number of memory cells activated during the subsequent response produce greater numbers of cytotoxic T cells and/or antibody-producing plasma cells. Another reason for the rapid response and increased intensity of subsequent exposures is that the antibodies produced from the first exposure are still available, and they are more effective in fighting the antigen. Immunological memory accounts for how individuals acquire immunity to many diseases. While resistance to certain pathogens may be present from birth, individuals must develop or acquire their immunity to many other pathogens, such as the flu or measles. Immunity may be acquired through natural means or artificial interventions. And here we see illustrated a summary of the immune responses. Nonspecific immune defenses, which are represented in the green, protect the body from all types of pathogens. Specific immune responses include the recognition of specific antigens by B and T cells. Activation of B cells produces an antibody-mediated immune or AMI response, represented in the blue. Activation of T cells leads to a cell-mediated immune response, or CMI, represented in the orange. Naturally acquired immunity is resistance that is obtained naturally without the intervention of modern medicine. Natural immunity is developed in two ways, actively or passively. Naturally acquired active immunity is developed through exposure to a pathogen in the course of daily life. Specific immune mechanisms respond and develop the body's resistance. For example, exposure to the varicella zoster virus leads to chickenpox. Once a person has had chickenpox, it usually results in lifelong immunity. In fact, it was common practice for parents to intentionally expose their child to a sibling or friend with chickenpox in order to develop immunity. With this exposure, the body actively engages in a specific immune response which develops memory cells and antibodies that provide future resistance. Immunity may also be naturally acquired through the transfer of antibodies from mother to baby during pregnancy or through breastfeeding. But since the mother's specific immune response are engaged in these processes and not the baby's, these are examples of naturally acquired passive immunity. The baby passively obtains immunity by receiving antibodies instead of developing them independently. Artificially acquired immunity is resistance developed through immunizations. Like natural immunity, it may be actively or passively acquired. Artificially acquired immunity is achieved through vaccinations. Often, these injections introduce either a weakened or dead pathogen into the body. Although these pathogens are altered, they still retain the antigen and thus initiate a specific immune response. In other cases, the vaccination contains a synthesized form of a specific antigen rather than a pathogen. This allows for greater specificity in stimulating the immune response and reduces the risk of introducing an unknown pathogen. So, as previously mentioned, natural acquired immunity is resistance obtained naturally, either acquired by active immunity or by passive immunity. And with artificial acquired immunity, resistance is developed through immunizations, artificially acquired either by way of active immunity or artificially acquired by way of passive immunity. Our table here illustrates immunity acquisition. There are 4 types: naturally acquired active immunity, naturally acquired passive immunity, artificially acquired active immunity, and artificially acquired passive immunity. With naturally acquired active immunity, the method of acquisition is exposure to antigen which initiates a specific immune response, resulting in the formation of plasma cells, cytotoxic T cells, and B and T memory cells. Once recovered, the body retains resistance through immunological memory. With naturally acquired passive immunity, antibodies are transferred from mother to baby across the placenta during pregnancy and through breastfeeding. With artificially acquired active immunity, vaccination delivers a dead or altered pathogen or synthesized antigens to initiate a specific immune response. This ultimately results in the formation of antibodies and long-lasting B and T memory cells that provide resistance through immunological memory. And with artificially acquired passive immunity, the method of acquisition is through immunization, which delivers antibodies to provide immediate but short-term immunity. Time now for our third What Do You Think segment. Create an analogy or story to highlight the differences between AMI and CMI. What types of artificially acquired immunity have you received? Are they examples of active or passive methods? Let's now discuss aging and the immune system. Many people live long and healthy lives despite the fact that resistance to disease and infection gradually decreases with age. Overall, the immune system simply becomes less responsive to foreign antigens that challenge health. As people grow older, most become more susceptible to several types of infection as B and T cells begin to respond more slowly. The overall number of T cells also tends to drop as the thymus shrinks and produces less thymosin. Decreased production of helper T cells diminishes specific immune responses, development of NK cells, and phagocytic activity. This decrease in the number and activity of NK cells helps explain why there is a higher incidence of cancer and other malignancies among older populations. Because the immune system of elderly people is less responsive to vaccinations, older adults are generally encouraged to get flu vaccines every year. Additionally, the incidence of autoimmune dysfunction increases with age, presumably due to some combination of the autoimmune triggers previously described. We should mention here that even as adults get older, we are finding more and more research that would support the fact that flu shots or flu vaccinations in and of themselves are not necessarily the things that are going to help elderly people to resist coming down with the flu. And so we are, as holistic health practitioners and natural health practitioners, we are seeing more and more evidence that there are other things, natural remedies in the environment that can help support the aging immune system. Now let's discuss Psychoneuro-immunology, or PNI. In the 17th century, French philosopher, scientist, and mathematician René Descartes inadvertently laid the groundwork for the future direction of Western medicine when he described the mind and body as having radically different natures. Descartes contrasted the mind, a rational thinking entity that could not be teased apart, and the body, which he characterized as a simple physical machine that can be broken apart into smaller functional pieces. In many ways, this view of mind and body as separate has served mankind and has led to remarkable medical advances. The ability to focus on and understand the body systems and individual organ tissues and even the cells has exponentially increased our understanding of the structures and functions of the human body. But it has also narrowed the focus of many Western medical practitioners, as it has become common practice to isolate a specific systemic or structural problem for treatment. This tendency in diagnosis and treatment not only overlooks the interdependence between the body systems, but often fails to consider the impact of emotions, attitudes, and beliefs on health and disease. Over the past 30 to 40 years, the emerging field of psychoimmunology has provided an abundance of scientific documentation that describes clear physiologic links between the mind and body. This field of study identifies and explains the connections between the psychological processes and the functioning of the immune and nervous systems. But PNI research has also shown that the term psychoneuroimmunology, coined by Robert Adler in 1975, appears to be incomplete because it fails to include the impact of the endocrine and digestive systems. So, by exploring the chemical and energetic links between the brain, digestive system, endocrine glands, and immune cells, PNI researchers have clearly described two body-wide communication networks. One network is the autonomic nervous system, and the other is the vast chemical network of peptides, or the information molecules. So, let's consider the peptide communication network, which consists of ligands, ligand receptors, and shifts in neurotransmitter production. The chemical communication system, described by PNI researchers, is a network created by peptides that travel throughout the body. These short amino acid chains include hundreds of chemicals characterized as neurotransmitters, endorphins, hormones, digestive peptides, or cytokines. Since all of these substances communicate and stimulate cells by binding with receptors on their plasma membranes, these peptides are collectively referred to as ligands, a term from the Latin ligar, which means to bind. Familiar examples of ligands are epinephrine, a neurotransmitter, and adrenaline, a hormone. Recall that epinephrine stimulates postsynaptic neurons whose dendrites are sensitive to this neurotransmitter, while adrenaline acts as a target cell with adrenaline receptors. While these ligands have different names and functions, chemically they are exactly the same peptides. PNI research has demonstrated that regardless of how a peptide molecule is categorized, or which system, organ, or tissue releases it, the ligand is capable of stimulating any cell that possesses a receptor for it. While ligand receptors reside on cells throughout the body, they are most concentrated in regions in the brain associated with emotions, particularly the limbic system. Scientifically speaking, this suggests that the communication web created by these peptides and their receptors provides a strong functional link between immune responses and emotional states. In other words, what we feel is reflected in what we believe, and what we believe is reflected in the chemistry of our body, a mind-spirit connection. In addition, I should have said a mind-body-spirit connection. So, in addition to neuroimmune links, fascial research has demonstrated neuroendocrine changes that are initiated through stimulation of mechanoreceptors in the abdomen. These changes include shifts in production of the neurotransmitter serotonin and histamines, which are key elements in the inflammatory response. These or other discoveries provide physiologic rationale for the gut instincts that tell us something before the mind consciously perceives it, and for the boost of the immune system receives from laughter and unconditional love. Let's now consider thoughts on holistic healing. The words health, healing, and wholeness all share the common root, how, of German origin, which refers to a state of being, complete, undivided, and integrated. The insights provided by P&I challenge all healthcare practitioners to consciously consider their beliefs and mental constructs about health and disease. If health is about wholeness, then disease cannot be limited to its biomedical definition. As we had discussed earlier, wholeness and a sense of well-being encompass the integrated and interdependent nature of the mind, body, and spirit. Therefore, disease is not simply a condition that impairs normal physiologic function, but anything that disintegrates us. In other words, disease is any disruption of the dynamic balance between the body, mind, and spirit to the point of causing physical, mental, or emotional trauma. There are times, however, when it is both helpful and necessary to think and speak of disease from a purely biomedical perspective. Without this perspective, there would be no cures or life-saving treatments for conditions such as fractured bones, appendicitis, asthma, malaria, or certain cancers. But curing a disease or repairing an injury does not always result in complete healing. We sometimes forget that healing is a process of returning to vitality and balance. It requires us to consciously and consistently make good choices in regard to nutrition, exercise, rest, work, play, and relationships. Healing is about moving toward health, and health is not simply the absence of disease, but soundness of body, mind, and spirit that reminds us that we are wonderfully alive. Let's now discuss the manual therapy applications with respect to our thoughts on holistic healing. The practice of manual therapy may include massage, movement, listening, mindfulness practices, specific kinds of breathing, energy balancing, and other tools and techniques. Many of these techniques have been dismissed by mainstream medical practitioners because the physiologic mechanisms for their effectiveness are not easy to identify, and treatment results are difficult to objectively measure. But if healing is seen as an ongoing process of moving towards health, a client's belief in the value of a particular treatment can have powerful benefits even if medical science cannot explain the physiologic mechanisms of its action. Some of the benefits of manual therapy are subjective and difficult to measure. Benefits such as improved mental focus, greater sense of ease in movement, decreased stress or anxiety, reconnecting or grounding, and an overall feeling of well-being have a profound impact on health and healing. Ultimately, the greatest therapeutic impact of manual therapy may simply be the facilitation of each client's individual healing process. To quote journalist Norman Cousins, "It is reasonable that science may not have all the answers to problems of health and healing." Time now for our fourth and final What Do You Think segment for this lecture. What examples of P&I at work can you give from your own life experiences? How might you integrate the information about the mind-body-spirit connections to help your clients? Okay, so we've reached the end of today's lecture, and for assignment number 12, we are going to be using the Thinking Beyond format to complete this assignment. What adjustments might you need to make when working with immune-compromised clients? How might you use words, music, color, and/or scent in your manual therapy sessions to support the immune system? And now that you have learned how the immune system works, how would you define healing? And as always, this assignment is due by Sunday, no later than 11:55 p.m. If you have any difficulty at all with this assignment, you may email me or send me a text message. My office hours are on Thursdays from 4 to 6 p.m. And with that, I will see you in the next lecture.